It's been a tremendous honor for us to be here and to allow the TB community in India for you to allow us to work on these issues and to think about a rights-based approach to care. I've worked on tuberculosis in Latin America and the Caribbean for almost 20 years now, and it's really quite humbling to think about the challenges here in India. I'm also struck by the tremendous opportunity that there is in a country this large, with this much human capacity, medical capacity, scientific capacity. Certainly the drug industry and diagnostics industries are here. As I mentioned at the start of the conference, the medicines we've used for many years in Haiti come from India. So I have no real doubt that the problem can be solved, but there's some tremendous challenges ahead of us, and I know we've talked about many of them. We wanted to include diagnostics because it's certainly an important piece of the puzzle, but also I think yet again a place where a rights approach and a rights perspective can help us organize and avoid difficulty. Among the challenges here, and one that seems most concerning to me as a newcomer to really intensely studying TB in India, is the question of drug resistance. We've talked about it briefly throughout the conference. It's something I know that will be discussed in continuation. And diagnostics play a great role in both avoiding, but oftentimes in creating drug resistance. Improper diagnosis, improper use of medications is the leading driver of drug resistance. Although, as the case series from Mumbai that we heard about the other day, if in any spot there are 25% of presenters who have MDR-TB and 45% of people who are previously treated, this is a big problem. And among other things, diagnostics, proper and rights-driven access to these diagnostics is an important piece of getting ahead of this. First, I'll introduce Dr. Reuben Swamickan from USAID. And I'd like to ask you to speak about ways that you see to increase access to proper HIV testing, and maybe a special comment on improving access to rapid diagnostic technologies. What are the promises and the pitfalls in that area?
Thanks, Evan, and good afternoon, everyone. I think a lot has been spoken over the last couple of days, and there's probably so much more to say. But keeping in tone with what's happening, if you look at RNTCP when it was first envisaged in terms of diagnosing TB, we have what we call a DMC, a designated microscopy center, and it was based on having one for every 100,000 population. So for a country of our size, 1.2 billion, you're expected to have 12,000 DMCs. The program currently has 13,000 plus. All right, so we've reached that tipping point in terms of access. All right. What was also crucial was that these DMCs were accredited. So in terms of quality, all right, the quality was already assured prior to actually starting. All right. Whether the quality continues to be maintained over a period of time at all 13,000 plus facilities is a moot point, but it's out there. All right. So that is public sector. In terms of a private sector and what the diagnostics have been like and where it's going, firstly, it is anything and everything that happens out there. All right. One thing I didn't hear in the discussions across the 2 days was the whole informal sector of healthcare in India. All right. We always spoke about doctors and the medicalization of it, but nobody spoke about the informal sector or unqualified healthcare providers, who are a huge number. All right. There are also unqualified labs providing services. Right, so that's another point that was not touched upon. Right, so in terms of quality that is being provided. Having said that, Government of India banned serology in May 2012. All right, and if you look at the kind of pie chart for serology at that time, almost 50% of the tests were serology. So when the ban happened, and it happened at a level which was at the manufacturing itself. So even if I didn't believe in the ban, I couldn't go out and purchase serology as a test or prescribe serology as a test simply because it wasn't available in the market. But that created a vacuum. All right, and the three major tests that were available, one was polymerase chain reaction, or PCR as we know it. The other was, of course, culture, which was always available, and TB Gold, what is known in India as TB Gold, a test that is commonly prescribed. So this was what was there. And we were fortunate at that time to have Gene Expert come into play, right? And Gene Expert tried to fill that gap to enable diagnostics there. All of this comes at a cost, right? So for patients who cannot afford, all right, these kind of diagnostics, it's just not available to them. Okay. Through a number of projects, mainly when RNTCP wanted to diagnose TB through Gene Expert and in-country kind of an evidence, that was provided around 30 sites, and now RNTCP has taken it up, and in their national strategic plan, they hope to set in place 950 Gene Expert machines by 2017. All right, that's very ambitious. The first 40 machines have already come in, and they are in play. And USAID has supported that in different forms. We are also supporting 30 sites with NACO to diagnose TB among all PLHIVs. So there are a lot of diagnostics in that sense that is happening. But just to move a little bit forward in terms of what's happening next, and what are the newer diagnostics. So firstly, on the horizon, there is nothing. All right. So what we have is what you will get. All right. We are pushing. USAID is now in a project with BIRAC, which is a biotechnology department, Government of India, and sometime early 2015, we will have a call for proposals for innovators to talk on TB diagnostics. So we look forward to that, and we hope that there will be some traction on that, and we get people who will apply, and maybe we'll see that. I think the difficulty is that it needs to be more high-end. It's not your homemade kind of diagnostic test that's there. Yes, we are looking for something that is better, faster, cheaper, and easier to use at point of diagnosis. But I don't see that happening. Hopefully, if there is some success there, we should be able to see it. So this is in brief the kind of scenario that's there. Maybe if there are questions, I can take them later.
Thank you, Dr. Swamickan. We'll move quickly to Dr. Singh from AIIMS, who's a physician and microbiologist with many years' experience in tuberculosis. I wanted you to pick up on, at least to start with, the ban on serologic testing for tuberculosis. And maybe you could comment further the use of newer diagnostics, Gene Expert or otherwise. Really anything you think we need to hear about diagnosis. I'll admit that as I'm sitting here through these last couple of days, and frankly before, thinking about the tremendous role and power for creating disruption in tuberculosis of the private sector, should I have been the boss, I think my policy would be to take isoniazid and rifampin off the shelves. And while that may not even be a good idea, certainly not easy to put into practice, we have an example of removing a dangerous diagnostic technology for the benefit of people, and I wonder if you could speak to that.
Thank you, Dr. Evan, and the organizers, Mr. Citro and all. So coming straight to my question in the interest of time, now let me take you back to how serology was banned, because I want to come to something beyond that. So when the serology banning, the RNTCP actually had to apply to DCGI after WHO had given a policy decision for banning serology. Now, despite the WHO's policy decision and the document having been available, it was a fresh exercise for us. Why? Because it all involved money. So the DCGI invited us as experts. I was the microbiologist expert representing the program. And so we were put across the table, and there were manufacturers sitting right across who had data which said their test was 90% sensitive, 95% specific. So those were the inserts they were using inside their kits. And that was the reason. So they were misguiding. And so I had, enough data from these kits were analyzed in Belgium, in the Institute of ITM in Belgium, Antwerp. So that data I had to actually flash. I'm sorry, I could be giving the institute name wrong, so I could correct that later. So that data clearly showed the tests were not more sensitive. It ranged between 9% to 50%. Nothing was more sensitive or more specific than that. So I wonder if all of us here understand sensitivity specificity, which means if 50% sensitivity or 50% specificity would mean that is the kind of sensitivity we offer. So 50% chances of diagnosing the test, 50% chances of misdiagnosing the test. So they actually had to be told the data from comparison studies for them to agree that their tests were not optimal. So this is where, and the kind of loss in market that these people would have had was then filled up, like Dr. Reuben just said, was filled up with anything that could take its place. So in the first place, these kits took a little while to be taken off the shelf, and when they were taken off the shelf, a very reputed laboratory, I wonder if I should name them here, the most reputed laboratory, at least in Delhi, had it on their website. The patients who are coming for serology diagnosis may be offered quantiferon. Now, quantiferon is another test which offers a lot of debate, and it is today being misused by quite a few laboratories to diagnose disease. Now, what quantiferon does is only diagnoses infection. And there has been a lot of debate trying to compare HIV and TB since morning. So the one major issue with TB is that one gets infected, and at a later date, which could be within a year, within 2 years, especially with children, or it could be 50 years, one could have disease due to reactivation of this infection. So quantiferon picks up infection and not disease. And what these laboratories, which had a lot of samples pouring in for serology, who did not now find serology, used the same samples to do quantiferon, gold test, what he mentioned as gold. And so now the next step for us from the program was to apply for a ban on quantiferon. Now, of course, it does offer some help in situations such as in pediatric population, where the other diagnostics sometimes fail. Now, I'll also come briefly to the different limit of detection of the other diagnostics. So currently, we are not able to actually work towards banning quantiferon, but we have at least put a stop to the license to the quantiferon by, DCGI wanted our comments on the import of this particular kit. So for now, we've at least told that. Now, of course, complete ban is the next step. So the problem there is the pediatricians are sometimes able to put this test to use, but now in the last year, we've had 2 publications from India. One was from AIIMS, Dr. Kabra, Dr. Lodha, who have shown the tuberculin skin test is as good as quantiferon, so it can be used as well, and quantiferon does not offer us any major advantage. The other paper from India, of course, there have been publications from Johns Hopkins who have shown that the reproducibility of using quantiferon they're done in healthcare workers. There was no reproducibility. I mean, there was very poor reproducibility, so it is not a good test. So, and there was an evidence from CMC Vellore, which just got published in 2014 by Dr. Madhukar Pai with 2 or 3 people from CMC, who have shown, again, in Indian healthcare workers that the reproducibility of the test is poor. So we are working towards putting a ban on quantiferon. Our problem is basically, if it was used for diagnosis of infection, we have no issues. But in the independent private sector and the private laboratories, which can misreport so often, they put it to misuse. And there have been treatments. Somebody mentioned reproductive age group female genital TB. So female genital TB is a difficult issue to diagnose because of the limit of detection of our test, which is not so good. These are the places where quantiferon, if given positive, gynecologists are misinformed, so we need to educate widely. They would start antitubercular treatment, and that is why we're getting to drug resistance. Now, if I'd also like to address drug resistance, shall I do it now or maybe a little later? The issues of drug resistance and how do we diagnose them?
Let's come back just to give everyone, and we'll all be conscious of time. Thank you, but I hope we do return. We'll go next to Hannah Brennan, who we heard from yesterday, a lawyer working with Public Citizen in the United States, a public interest law firm. And wanted you, Hannah, to speak to some of the ways that law and patent law, potentially TRIPS agreements and regulations, can potentially help rational use of diagnostics or increasing access to them. You mentioned Gene Expert in your presentation yesterday, which is, a good test, but fairly expensive. So take it where you will, but on this question of how law can inform the use and access and right to good diagnostics.
So the doctor here spoke a little bit about how the access to the expert is going to be very difficult because it's so expensive, and I completely agree. You have this great diagnostic technology, but it's going to be impossible for most places to buy it. And not only because the diagnostic itself is very expensive, but also because the maintenance on it is going to be extremely expensive. The machines will break down and they'll need to be maintained, and this, the company that makes it will have sort of a monopoly on doing that maintenance. So it really, they're sort of celebrating this expert diagnostic as a great change and move forward, but it really won't be unless it's affordable. And I think there's a lot of room for patent law to change that, and specifically the right to health. So Lucina yesterday was saying how that there's very different communities within the TB community is very different than the HIV community, and maybe the TB community is a little too nice in comparison to the HIV community. And that's true in the law as well. The IP community is very distinct from the human rights community, and the two don't really communicate. IP lawyers in the US, for the most part, are interested in defending the companies that have patents because you can make a lot of money doing so. And the human rights lawyers have not really taken an interest in IP and how important it is for access. But I really think, and sort of the projects we're working on at Public Citizen, that there may be a space for human rights law to inform intellectual property law. So not only through the compulsory license mechanism saying, compulsory licenses must be granted because of the right to health, but also perhaps in patent oppositions themselves. There's space for the use of human rights law in patent oppositions and patent invalidations, and people just haven't really explored that space yet, but it really needs to be, in my opinion. And just one last comment. So the Special Rapporteur on the Right to Culture and Science is working on a new comment. Article 15 of the Covenant on Economic, Social, and Cultural Rights says people have the right to benefit from science. And a lot of people interpret that now as a right for pharmaceutical companies to benefit from their scientific products. But the right was not written that way. It was not meant to protect any sort of pharmaceutical company. It was meant to protect people's right to access science. So there really is a lot of good human rights law out there and human rights treaties that would enable people to have access to these types of diagnostics.
Thank you. Dr. Pandey, Kiran Pandey is a colleague and friend of ours from the University of Chicago, from a neighboring small country to the north, from Nepal. I wondered if I intentionally didn't tell you what I would ask you, just to give you a chance to take it where you might. I wondered if you could talk a little bit about providing diagnostic services to a population. And with your experience, I know in rural, poor Nepal, where one of the challenges is explaining and helping people understand these diagnostic tests with their limitations. Could you talk a little bit about the right to knowledge, or how this is actually practiced out down to the level of a patient and interaction and creating understanding of a very complex issue?
I probably must start with an admission, by admitting the fact that we probably never did a good job around it. We had an entire mechanism to do the same thing with our HIV patients. Never did that with TB. And I admit that I'm faulty of that. Our entire system was faulty of that. There never was an understanding that explaining it to the patient would be a good thing to do. So we never did it. So there's a very short and honest answer about it. The other point, and we had our own frustrations as well. Working out in the community, you can't ask me how many times I've been so unhappy and so frustrated at how difficult diagnosing TB out in the community at times can be with the kind of technical tools that we've had available up there with just, I mean, plain old sputum microscopy, something that's been around for 100 years, and I mean, X-ray, which has been around for 100 years without much change. So those were frustrating experiences. Could we have done better? Probably. I mean, yes, if we bent our back in order to try and do it. But within the system that we'd created, I mean, a very program-driven system that was just focusing on achieving the 70% case detection rates and whatnot, and not a demand-driven system, I think, I mean, that was only the best you were going to get with that kind of system. I mean, if you're talking about what we're trying to talk about today and trying to create a rights-based approach around the whole thing and trying to create a demand-driven approach to the whole thing, it might have been different, because HIV was a demand-driven healthcare delivery system. TB never was that. TB was just about, I mean, putting some check marks against specific targets in a program that was very, programmatic in focus. It was not actually about the individual at the center. So that's how things were, and that still, I must admit, things are still that way, and these things need to change.
Let's return quickly to the question of drug resistance before we open up to the floor. I hope everyone's aware. If you're not, we'll mention it. Treatment for drug-susceptible tuberculosis in India is about 800 rupees from beginning to end. Treatment for drug-resistant, multi-drug-resistant TB is, on average, 275,000 rupee treatment. It's drastically underestimated, as we know. More complex to diagnose, and very complex to treat. I want to thank again our presenters from Ethiopia and from Western India talking about psychosocial support for people going through treatment for drug-resistant TB. We don't grudge cancer patients psychotherapy and psychological treatment when they're undergoing chemotherapy, which is often of shorter duration than MDR TB treatment, and often similar or fewer side effects in some cases. MDR TB treatment is tremendously burdensome for patients and providers for reintegration into community. It can leave lifelong physical scars, certainly lifelong psychological scars. Talk a bit, as you were heading to, about drug resistance and what we might need to know here in a few minutes.
Yeah. I'll take from where Dr. Kiran left. Like he said, the program should have been a demand-based, which if we go back a few years, the Indian National TB Control Program was actually demand-based. The program would not really go out to the patients. They would wait for the patient to come to them. And the other difference was the X-ray alone was being used as the diagnostic modality in the earlier, the program which was called the National TB Control Program, till it was revised to the revised National TB Control Program in 1992-93. When they shifted to an active, it's actually symptom-based, but then the surveillance is done using smears. Now, the diagnostic modalities that are available with us are smear microscopy, the culture, and now we have molecular-based methods, of which PCR is one Dr. Swamickan mentioned, which has its own issues. I'm not going to talk about that. And what we have with us is the gene expert, which is again another molecular-based method. Now, the limit of detection of all these three are like this. For the smear microscopy to be positive, we need 10 to the power 3 to the 10 to the power 4 bacteria per milliliter of the sample. Culture needs fewer, that is about 100 bacilli per ml, and so does gene expert. Right? Now, I'm trying to actually put in a lot of, I'm trying to simplify facts, and so I might miss a few things. Kindly excuse me for those. So when we talk of drug resistance, how does drug resistance come about? In the replication cycle of bacteria, what happens is 1 out of every 10 to the power 6 or 10 to the power 8 bacilli would get a mutation naturally. So if these patients who are on treatment, if some patient who's on treatment is given single drug therapy, the resistant bacteria, the bacteria resistant to that particular drug selects out. So this is how we say drug resistance is a man-made phenomenon. If there is poor prescription, that is fewer drugs are prescribed, the prescription has not actually been tested in patients. So that is how it's a man-made phenomenon. So drug resistance could be occurring naturally, but the selection of drug resistances is by poor prescription. So this is where I bring in what Dr. Swamickan had initially mentioned, poor prescriptions by registered medical practitioners who are not actually trained physicians who just give any combination of treatment, add any number of drugs or subtract any number of drugs, and so on and so forth, which is a difficult group to actually control and educate. So that is another problem at the periphery. Now, when we talk of drug resistance in Mumbai, what Dr. Evan mentioned, so those hotspots of drug resistance are basically there due to increased transmission in urban slums. And that is not the story of only Mumbai. That could be a story of all urban slums. So it's just that we are aware of that. It's the tip of the iceberg, but there's a huge, big iceberg which may actually be, unreported because the transmissions go on. And this is where like Dr. Sharma mentioned, TB is different from HIV. We need to diagnose it early. We need to, act early. So early diagnosis, early treatment, and proper, correct treatment are the only modes of control of the disease. And that is why, early reporting. So early diagnosis of a sensitive TB as well as a drug-resistant TB, so that we curtail the chains of transmission in the community. So Gene Expert comes in here. I'm not a promoter of Gene Expert, but the only advantages it gives us is it gives us a quick diagnosis. It gives us in 2 hours we get the diagnosis, and it picks up drug resistance in any sample which has 100 bacilli. So we would still miss samples which have fewer than 100 bacilli, non-cavitary disease, even in HIV patients where the cavity is not being formed so well because of the pure immune response, the diagnosis may be missed. So we need to then follow up these patients and diagnose them later. And as far as the access to expert machines is what Hannah just brought out, like Dr. Swamickan said, there are going to be almost 1,000 machines available to the community under the program, 1 machine per district with the district hospital, and the diagnosis is achieved within 2 days. Of course, the issues of the company having monopoly and so on, those issues will have to be tackled later. So I guess so much for now. More I can answer to the questions. Thank you.
Thank you. And let's I know we're running a little late and have some final comments, but let's open up for a few 10 minutes of questions. I see 1, 2, and 3. And if you have someone you'd like to direct the question to, make that clear. First, our Dr.
Dr. Rajesh, I'm working with National AIDS Control Organization for HIV and TB. It's not a direct question as such, but I would like to highlight one issue which I feel very important at this forum. As Dr. Reuben has already mentioned, there are a range of diagnostic practices which are practiced in India in different states. So if you go to some states in north, you have different practices, and depends on the practitioners there and the proportion of qualified practitioner in that particular state. What I want to highlight is there is an international standards of TB care which highlights the standards of diagnosis in its important standards. India has also developed standards of TB care in India, which also has focus on the standards of diagnosis. The international standards of TB care, what I want to emphasize is a very good tool which can be advocated to this sector, specifically the private sector. But then the awareness regarding the international standards of TB care or the standards of TB care in India is very low as such, and the practices which are followed are different. So if we are increasing the awareness regarding the standards of diagnostics, we'll be able to actually do something good in this one.
Urology, Dr. Urvashi. I think you left out a small detail in that. Actually, civil society lobbied quite a bit behind the scenes, meeting the planning commission, and so I think, together I think that was a great achievement. But what happens with implementation? It's a great thing, but I was part of the joint monitoring mission. We were at a remote place. We went to one of those hole-in-the-wall laboratories. There was a letter from probably from the same lab that you were talking about, saying that this has been banned by the government, but in its place, please use quantiferon gold, which costs, I don't know, 3 times maybe. But then what happens? There is no mechanism to deal with non-compliance. I mean, it is a gazette order. I mean, how? So for me, that is an issue. If all these things can happen and be, decided, and guidelines, orders put out from the court, and nobody is following it, we have no mechanism to deal with it. Has the lab lost their license? No. I mean, so it's just something for us to think about. Otherwise, I think all the efforts will just go down the drain. The second thing is about Gene Expert. Yes, I do agree. Just a comment to Hannah. It's the best we have. I agree. But it's not just the cost that is an issue. It is still sputum based. How do you get sputum out of a 1-month-old baby? There are major challenges. So for me, it is an issue why we are not demanding for better tools. Where is the, why aren't we up in arms asking for more R&D, for better diagnostic tools that will work in children, that will be non-sputum based? But we've kind of, Gene Expert came and we've all said, oh, fantastic. And yes, you get the results in 2 hours, but it still only detects rifampicin resistance. So yes, it's good what we have, but that's not the end of it. We do need to demand for more. And I think it's not just the role of the advocates to do that. Even the medical people, the biomedical people need to be demanding for more research into newer tools that will actually work for everybody. I mean, the Gene Expert, I don't know, you might be able to answer this. The results are not 100% in, whatever, 98, 90. 6 in HIV positive people as well. So I think there is an issue with it, and I think we need to put it down saying that we need better tools, that are non-sputum based.
So can I respond now?
Of course. We're very aware of the lack of new technology, both for treatments and diagnostics, and in an intentional way left that elephant out of the room. But please, this is a tremendous fundamental issue, but we did choose to move from it. But please comment.
So quickly to the first point that you raised, yes, like you said, so this had bothered me as well. So we are working on the quantiferon ban, but at least we have, initiated this, that the DCGI is no longer giving a license to them. So we are trying to strike at the grassroots. The test is not available. How would they put it to use? And the quantiferon people came running to all of us. Do something about it. Yeah, do something about it. So I said, yes, we would see what we can be, So, but then there's this pediatrician lobby, which is not yet allowing us to actually go for the ban. So far, at least we're trying to do a bit. And when you say more R&D, that is what, when yesterday also you said up in arms. It's good to use those words, but you have actually got to see the amount of effort that goes into research, trying to get new diagnostics. We ourselves in our laboratory, several of these researchers in India, abroad, all over, so much money flows into, new R&D for newer diagnostics. We are very well aware of the need for new diagnostics, and there's a lot of research going on. Of course, like you say, it may appear to be slow, but yes, a lot of work is going on, and till such time that we can actually get something on the table, it's not there. And as far as the 1-month-old baby, you said, we can take a gastric aspirate. We do gastric. There is no other way to diagnose a small baby. No. So that is the way we diagnose everything for small babies. That is the way each of the diseases is diagnosed. Of course, that is the way it works. So you have to look at the pathology, pathogenesis of the disease as well. Every disease presents differently. So we have to work around ways of working with that disease. Thank you.
The latest R&D report.
Yeah.
The global R&D report.
Earlier, when I used the word demand-driven, I didn't realize it could create confusions, because the demand-driven approach that I was talking were kind of similar. The demand-driven approach Dr. Singh was talking a little different, so it was not a regression that I was talking about. So sorry about the confusion. The second, although I agree with much of what you said, I would still go for a test that would diagnose TB based upon a sputum sample, because there's great benefits to doing that. it tells you who's infected, infective and who's not, and all that sort of thing. I'm sorry. So I would still not go, I mean, would despise a sputum-based sample. I agree that there is a great deal we could do about it. The third point, let me try and answer this in bullet points. And I think we tried to write a little bit about this as well. There has been at least $6 or $7 billion in funding shortfall over the next several years that has easily been documented in TB. So you're right about saying that there is not enough R&D happening in TB. And a more rights-based approach would address issues like this. So this is why we're trying to get into, these lines of thought.
It's currently working in India, 4 cities, so it's not yet published, so obviously it's not out there. But just to keep you all informed, working in 4 cities, it's on just for the last 13 weeks only. We've got some phenomenal results, all right? These are children below 5 years of age, all right? I think it's close to 400 tests per day, 4 sites, so about 1,600 per week is the number of tests done. That's the capacity, so it's a little bit less than that. But we found 27 rifampicin resistant patients who would not have been diagnosed otherwise, 1. 2, they're working with all samples. The specificity and sensitivity for urine and stool, which will become the gold test finally, because all children will pass urine and stool, and so you don't need to do any invasive method to diagnose it, is around 88%. So they're not very happy with that. So we're working on improving that. So once it gets closer to 100, that's when you'll want to use that as the gold standard. But the point is that I think they diagnosed close to 200 plus TB patients, of which 27 were RIF resistant. So it's working. It's out there, and once we have the results, we'll take probably another 6 months to look at it. And these patients are all from the private sector, right? So so that's another hand-holding that's being done to private sector. Currently, it's free because it's in the project, all right? So we'll have to think about ways of how that moves forward.
Thank you. Next question, and then maybe one.
It's confusing, and I just want to put that the comparative utility of Mento test versus this TB gold test, 1. Secondly, I am getting some student going abroad for education, in particular US, in the medical fitness form which is being asked from us. Then while in the history of medical, the TB history, they ask X-ray, Mento, and gold, TB gold test. I just want your comment.
Infection. While in India we do not have that policy, because even if we treat, we would get reinfected because of the endemicity of the disease.
A situation will come. You are in the process of heading toward banning the gold TB, and if that column in the form persists, then how it will be done?
Okay. Okay. So if there's a ban, they would also be aware. Yeah. So already there may be a problem with this license of the quantiferon being, but of course we have a TB platinum taking its place, which is, now I must inform the audience, which was actually a Chinese company which came into India, and now they're manufacturing in Hyderabad. So if any people from Hyderabad, now they're manufacturing in Hyderabad, so they don't even need a license from DCGI for importing it, because they have a license from Hyderabad. So in a country, we not only, I don't want to say our country is the only one that faces corruption. There's a whole list of countries which have such things ongoing. So actually we need to target those issues as well. So it's as difficult as that.
Point here is that this tuberculin test is more useful than this gold TB test.
Because I said that, yes. So you see, when quantiferon actually started selling, this was one of their sales gimmick, that quantiferon is more sensitive than TB, than TST, and also there is no cross reaction with BCG immunization. That was their sales point, but which has been disproven. That's why I highlighted the Indian studies. BCG is part of the EPI here, and BCG all children are given. Despite that, this particular study highlights that TST was as good as quantiferon. So you could, if you'd like, I can send that paper to you. Otherwise, it's simple. Loda et al. 2013.
Thank you.
I would like to ask you, what is the role of ESR in the diagnosis of tuberculosis?
Very good question. Now, these tests are such that we've always observed over the past few years that they go hand in hand with the TB activity, and until such time that we had a good diagnostics for extrapulmonary TB. A lot of orthopedicians, surgeons, gynecologists were using that as a marker for TB activity.
They are,
Yeah.
the ground conditions are different. Even now they are banking upon ESR and start the ATT in such patients.
You see, it would not be ideal to actually just start the treatment based on ESR alone. If at all they're doing it, they may be, having enough clinical evidence, radiological evidence, and in the absence of pathological or microbiological evidence, they may be just using ESR. But I'm not of the school of thought that ESR can just be thrown into the bin. ESR, along with a strong clinical suspicion, a strong radiological suspicion, can be utilized. There are times when you have to depend on radiological and clinical evidence in the absence of other
Thank you.
evidence.
Thank you. I think we'll wrap up and maybe just take a minute to stand and stretch before our closing comments. Thank you, everyone.